Well, hello everyone. Welcome to the All Things Celiac webinar series brought to you by the National Celiac Association and the Harvard Medical School Celiac Education and Research Program. Given that February is Heart Health Awareness Month, our appropriate webinar topic for today is heart health, body weight, and celiac disease, what we know, what we don't know, and what to eat. My name is Chris Rich. I am the CEO and Executive Director of the National Celiac Association. We at NCA provide educational resources to our celiac community, such as this All Things Celiac webinar series, and we continue to value the opportunity to work in collaboration with the Harvard Medical School Celiac Education and Research Program to bring such initiatives to you. In addition to our educational programs and efforts to provide for those facing food insecurity, the National Celiac Association offers an extensive support network that reaches from coast to coast and assists everyone from kids and their families to our celiac seniors. You can find more information about the ways that we act as the voice of our community on our website at nationalceliac.org. The highly collaborative Harvard Medical School Celiac Education and Research Program was founded in 2013 and has a twofold mission of developing and promoting the latest research in celiac disease and advancing awareness about celiac disease through educational programs to clinicians and the general public. Education is at the heart of the HMS Celiac Education and Research Program, and these webinars continue to feature multidisciplinary speakers with specialized knowledge on celiac disease, related autoimmune conditions, and nutrition. Some housekeeping things for us before we get started. For today's event, you're welcome to ask general questions through the Q&A feature. That's located in the bottom right of your Zoom screen. Closed caption is also available by clicking on the CC button. For those of you who have registered for continuing education units, please fill out the survey that will be added to the chat box during the webinar. And if you're still struggling to connect with us, tech support is available if needed at digitalmedia@partners.org, or you can reach us by phone at 857-282-6470. This session is also being recorded and will be available for viewing on the National Celiac Association's website. That address again is nationalceliac.org. Our moderator today is Sharon Weston. Sharon's a board-certified specialist in pediatric nutrition and is certified by the Culinary Health Education Fundamentals Coaching Program at Harvard Medical School. She's been in practice for over 30 years and is currently senior clinical nutrition specialist at Boston Children's Hospital, working with a variety of patients within the gastroenterology, nutrition, and endocrinology departments. Sharon's a member of the Boston Children's Hospital Celiac Program Team, the lead registered dietitian for the Optimal Wellness of Life Clinic, and a member of the BCH Diabetes Team. She hosts monthly virtual cooking classes for the BCH Food Pantry, specifically designed to highlight gluten-free recipes and promote wellness using food as medicine. Sharon recently co-authored Applications of Culinary Medicine in the Pediatric Gastroenterology, Hepatology, and Nutrition fields in the Journal of Pediatric Gastroenterology and Nutrition. So I'll get started by saying hello and welcome to Sharon.
Thank you very much, Chris, and thank you for that very kind introduction. I also want to thank NCA, and I'm really honored to be here today to moderate today's webinar topic on heart health, body weight, and celiac disease, what we know, what we don't know, and what to eat. Just to review what Chris went over, please use the Q&A at the bottom of your screen to just submit general questions for our three speakers. We'll do our best to address as many questions as possible during the discussion portion of today's webinar, but if you have any questions that might not be specifically related to today's topic, we encourage you to really visit the NCA website where you can access previously recorded webinars that may cover that information that you're looking for. And again, I'd like to remind everyone that today's session is being recorded. It will be available for viewing later on the NCA website, and the CEUs are available for dietitians, nurses, physicians, social workers who have pre-registered for the webinar. And please fill out the survey that will be posted in the chat section during the webinar. So I am honored to introduce our first speaker, Dr. Peter Green. And Dr. Green attended medical school at the University of Sydney, Australia. His gastroenterology fellowships were completed at the Royal North Shore Hospital in Sydney and at Beth Israel Hospital in Boston. Education, where he was a research fellow at Harvard Medical School. He's currently the Phyllis and Ivan Seidenberg Professor of Medicine at Columbia in New York, and also is the director of the Celiac Disease Center there. He has received many honors, including the American Gastroenterological Association, AGA, Foundation Mentors Research Scholar Award in 2007, the American Society for Gastrointestinal Endoscopy, or ASGE, Master Endoscopist Award in 2007, the Master of ASGE Award in 2020, the AGA Research Mentor Award in 2020, and the Distinguished Clinician Award in Academic Practice from the AGA in 2021, as well as the Mackey Celiac Disease Tempari Prize. And I would like to ask Dr. Green to share his screen and we'll get started.
How's that?
Looks great. Thank you.
Very good. So thank you very much for that kind introduction, and to Chris and Melinda for inviting me today to this session. So this is what I was presented as the title. So I thought I will address some of the questions on obesity and celiac disease. Now, a lot of the information that I'm going to present is from our research at the Celiac Disease Center. So I really don't have any disclosures concerning this topic. So as we all know, gluten is the term for the protein of the cereal grains, wheat, rye, and barley. And you can see from this genetic tree of the grasses that they're closely related, and these other grains that are safe for people with celiac disease are more remote genetically. Now, this is a grain of wheat. This is a whole grain, right? And the endosperm is where we have our white flour from. And this has few vitamins and minerals, but the whole grain is very healthy, with the bran containing vitamins and minerals, as well as the germ part of the grain. And you can see this whole grain is healthy. However, during the milling process, in which the endosperm is produced into flour, there's loss of vitamins and minerals because the germ and the bran are not included. But now, after the First World War, all around the world, wheat flour is fortified with vitamins and minerals, and it becomes healthy again. However, the gluten-free flours are not fortified. So, and this contributes to the gluten-free diet not being a very healthy diet. Now, just talking about obesity, this is some of the data from our Celiac Center. And so this is a female US population BMI from the National Health and Nutrition Examination Survey. And you can see that only 3.5% of women were underweight. About a third had a normal weight, a third overweight, and a third obese. And then when we looked at the BMI of our patients at diagnosis, you can see that virtually 70% of women with celiac disease have a normal BMI, only 15% underweight, but certainly you can have obese patients. Now, in our follow-up, we found that the underweight patients gained weight and became normal, and the overweight and obese patients came back down towards a normal BMI. And this correlated with seeing our dietitians and getting intensive dietary care. Then when we looked at interestingly, I'll just put in this about the height. We were interested in what the height of individuals with celiac disease was, because we kind of thought that the men looked a bit shorter. And true enough, comparing the height of the celiac patients seen in the Celiac Center with their NHANES, you can see that men were shorter than their peers in the national population. And what was also very interesting is we found that females were somewhat taller than the average population in the NHANES data set. So there appears to be this difference in gender in response to the inflammation in the development of adult height, which has not been explained. So looking at children in the Celiac Center, this is 300 pediatric patients, of which 57% were girls. Once again, the bulk of patients had a normal weight, normal BMI, underweight, but you could also be obese and have celiac disease. And then when we looked at the groups in which we had both the initial BMI when they were seen and the follow-up, and here you can see the initial BMI and then a follow-up. So the children that were underweight mainly became normal. The normal ones remained normal, but some actually became obese on the gluten-free diet. And the overweight children, about half of them normalized their weight, BMI. And the group that came towards normal, this correlated with their adherence to the gluten-free diet. So there's great advantage for a child to be adherent to the gluten-free diet to normalize their weight when both underweight and when overweight. And then it was interesting for us to look at the variation in presentation and how this varied with BMI. So the top group, this is those that had a normal BMI at presentation. B were those that were underweight, and C were overweight. And you can see that the underweight children, more than a half actually presented with their failure of growth, either underweight to start with or losing weight. Whereas those that had a normal weight and were overweight were more similar in their presentations. And you can see that the major mode of presentations for these children were recurrent abdominal pain and screening. And the kids that get screened here were those that were first-degree relatives of patients, Down syndrome, and autoimmune diseases. But and quite clearly those that were underweight, more than half actually presented because of this weight issue. Now, I just want to recommend this recent review that was led by Jonas Ludvigsson from Sweden, and there's Ben and myself from the Celiac Center here, and Dan from Boston. And this is quite a thorough review of complications and comorbidities of celiac disease. And this was in Nature Reviews, just came out recently. And this is one of the diagrams from this review. And these are some of the manifestations and comorbidities. You know, the syndromes are Down and Turner syndrome, these diseases that are associated due to common autoimmunity. And then a lot of these complications that we see are related to the chronic inflammation. And these were the main complications that we considered: non-Hodgkin's lymphoma, heart disease that we'll talk about more, small intestinal adenocarcinoma, fracture risk, adverse pregnancy outcomes, anemia, thyroid disease, psychiatric disorders, anxiety, and bacterial infections. Now, what about cardiovascular disease, which is the main topic of the presentation today? You know, there are multiple studies that show an increased risk of cardiovascular disease for people with celiac disease. There's multiple Swedish studies, mainly led by Jonas Ludvigsson from the Karolinska Institute. And it's been a very wonderful experience for us collaborating with Jonas. And you can see when you look at the hazard ratio, 1 is equal to the population as a whole, and 19 is, so a hazard ratio 1.19 is like a 19% increased risk. And you can see that these had an increased risk that was small. Now, this is a relatively small increase, but there's increased risk of angina or a myocardial infarct, increased risk of stroke, which is a 10% increase, and increased cardiovascular mortality, which is an 8% increase in people. This is the value in doing Swedish studies is that we can look at the whole Swedish population, about 40,000 people with celiac disease compared to representations of the entire Swedish population because of the uniform healthcare system and everyone receiving a specific healthcare number at birth that gets carried through until you're not around further. There was a Finnish study that showed an increased cardiovascular disease risk in people with celiac disease, but not those who just had dermatitis herpetiformis. And then this very great UK biobank study that showed a 44% increased risk for cardiovascular disease in people with celiac disease. And then a further study looking at the Swedish population showing a 34% increased risk of atrial fibrillation. So multiple studies from multiple parts of the world demonstrated this increased cardiovascular risk for people with celiac disease. Now, like what could the mechanism of this be? People with celiac disease appear to have a lower risk. So how can we explain this? Individuals with celiac disease have a lower total cholesterol, the BMI is low, there's less smoking, and typically the blood pressure is low. But there are aggravating factors. HDL, which is the protective form of cholesterol, is low and can be very low in individuals with celiac disease. And there's this chronic inflammation. And then there's this lingering consideration that actually the gluten-free diet is not a healthy diet and may in some way be contributing to this increased risk. Now, the gluten-free diet is quite amazing. You know, people can be very sick and they find out they just have to change their diet and it turns their life around. It's an amazing therapy. It's improved innumerable lives. It's generally effective in most patients. It's generally safe in the long term. There is the potential for nutritional deficiencies. The tolerability of this diet does vary, and it is difficult to maintain in our current modern day life. Now, I say it's not a healthy diet because as I showed with those whole grains, like a whole grain is rich in fiber, iron, and B vitamins, and the gluten-free diet can be deficient in these elements. And then you have manufactured gluten-free products that to counteract the lack of taste due to lack of gluten, you can have salt, fat, or sugar added. And there is this lingering issue of increased heavy metals in individuals who are on a gluten-free diet. Now, this increase is often not in the toxic range, but it can be high in lead, mercury, or arsenic. And then I will talk about one of these studies that show that individuals who don't have celiac disease but have a low gluten intake can be associated with increased risk of type 2 diabetes and heart disease. And specifically, I want to talk about this study of long-term gluten consumption in adults without celiac disease and risk of coronary heart disease, a prospective cohort study that we performed along with the people in the School of Public Health at Harvard. And this looked at the nurses' health study and the health professionals follow-up study and looked at over 100,000 individuals in which we developed a gluten index and divided people, this whole population, up into fifths. So the highest fifth had the most gluten intake and the lowest fifth had the low gluten intake. And what we found was those that were in the highest fifth had a lower rate of coronary artery events than those in the lowest gluten consumption group. So it appeared that those that ingested gluten had a cardioprotective effect compared to those in the lowest group. Now, it wasn't a lot of events. It was this number of events in the high gluten group compared to this number in the low gluten group. And when we controlled for various factors, it was considered that there was lower consumption of whole grains. So it appears that people who avoid gluten tend to avoid all grains, and especially those healthy whole grains that contain the nutritious part of grain. And because whole grains appear to have a cardioprotective effect. Now, I've got to emphasize this as a non-celiac population.
Yeah, 2-minute warning, Dr. Green. Thank you.
Okay, so what's the role of mucosal healing? So it's a little bit controversial, but when the mucosa is healed, demonstrating follow-up biopsies, one study showed that those people that had persistent villus atrophy had increased mortality, whereas when we looked at the Swedish study, persistent villus atrophy was not associated with increased mortality. And so this is shown in this graph that these are people who had persistent villus atrophy, and it showed persistent low bone density, increased risk of various malignancy, and increased mortality. Now, the American College of Physicians recommend assessment of the atherosclerotic vascular disease risk using specific questionnaire. And these are some of the factors that, looking at patients' age, their race, total cholesterol, HDL cholesterol, blood pressure, whether diabetes, and whether they're a smoker. And as I had mentioned, that this does not apply to people with celiac disease, because despite having an increased risk, they have these good cardiac factors of low BMI, low blood pressure, low cholesterol, and they tend to not smoke. So we really need to develop a risk calculator for people with celiac disease. But we don't have that, unfortunately, because we get a false impression here. So it's very important that the dietitian has a role to make sure that the gluten-free diet is a healthy diet. Because as I pointed out, whole grain intake is inversely associated with coronary artery and cardiovascular mortality. So many patients with celiac disease know what to avoid, but not what to eat. And to my mind, that's the most important role of the dietitian. The dietitians have tremendous role, and it's been most educational to me to work very closely with our very smart dietitians. To my mind, the role of the dietitian is to ensure that the gluten-free diet is a healthy and varied diet and is enriched in whole grains. So I think I made it on time. So I thank you very much for being involved in this symposium. I look forward to listening to the other speakers. That's my email if you like to get to it. We have a lot of information on our website, and we're holding our biannual international meeting May 1 and 2. Everyone's more than welcome to sign up, go to our website. So thank you very much for involving me.
All right. Thank you so much, Dr. Green. That was an excellent presentation, and I love how important the role of the dietitian is that you pointed out. Thank you. So I would now like to move on to our second speaker, Dr. Jacob Hartz. Dr. Hartz is the Director of Preventive Cardiology at Levine Children's Hospital in Charlotte, North Carolina. For the past 5 years, he was has been the director of preventive cardiology at Boston Children's Hospital, and his research focuses on reducing the risk of cardiovascular disease starting in childhood. He has been the PI for projects sponsored by the National Heart, Lung, and Blood Institute, evaluating the use of financial incentives to improve medication adherence in youth with familial hypercholesterolemia. And he has also been the PI for industry-sponsored trials. Dr. Hartz received his medical degree at the University of New Mexico School of Medicine. He completed his pediatric training at Duke and his pediatric cardiology training at Children's National in DC. He earned a master's of public health in health policy from Columbia University. And I'd like to ask Dr. Hartz now to share his screen.
Great. Thank you so much for including me. This is a real honor and treat. I want to talk to you all a little bit about celiac disease and cardiovascular disease risk in youth. And we're going to go through it really expanding on what Dr. Green just talked about. So I don't have any relevant disclosures. So let me get rid of this. Okay. And so today we'll talk a little bit how we determine someone's cardiovascular disease risk in general, and then we'll describe those drivers of cardiovascular disease risk and why gluten-free diets and patients with celiac disease complicate this picture, and then describe some celiac-specific disease risk factors. All right. So I think the first thing to talk about is understanding what is the main driver of cardiovascular disease risk, and that's the development of atherosclerosis. So the development of atherosclerosis leads to the thrombi that lead to heart attacks and strokes, and lead to vessel narrowing, leading to angina and claudication in the legs. And we need to understand what drives that. And once we understand what drives that, we can have a little bit better understanding of how celiac disease may fit into this picture. And we often talk about someone's lipid profile. And we talk about it as if it's one thing and everything in there is of the same mechanism. And I want to really emphasize that on your lipid panel, you'll see something called triglycerides, and they look like this. That's what a triglyceride looks like. And then we'll also talk about something called cholesterol, and cholesterol looks like this. And they are measured in the same lipid panel, but they're clearly different. And triglycerides are a great source of energy. They're important for cell membrane fluidity in your brain. Cholesterol is important in hormones. Vitamin D is its backbone is cholesterol, cell structure, and myelin, which is also part of your nervous system and brain. And so although we talk about them together, they are actually very different, and things that increase the triglycerides in the lipid panel are very different than the things that increase cholesterol. So I want to talk about a couple things first, and these are how we get these triglycerides and cholesterol through the body. And the first thing we want to talk about is chylomicrons, because that's what we absorb, how we absorb fats and cholesterol from our diet. And they become something called chylomicron remnants after they're processed through the body, which we can really just think of as they have delivered the triglycerides to where they need to go. Oops, I've lost. Okay, there we go. A little out of order, but that's okay. The next thing I want to talk to you about is something called very low density lipoprotein. And that is the equivalent to a chylomicron, but it's what you make in your liver. So when your body makes triglycerides and cholesterol and needs to send them out, it comes through something called VLDL, or very low density lipoprotein. And it gets processed and becomes something called intermediate density lipoprotein, and gets processed further into something called low density lipoprotein. And although I sort of ruined the punchline with the order of my slides, the VLDL IDL, LDL, chylomicrons, and the chylomicron remnants all have something called ApoB. Another thing that we talk about is HDL cholesterol, or the cholesterol carried in this thing called HDL, which stands for high density lipoprotein. And it has something called apolipoprotein A as its backbone. So you can see everything on the left of the slide has ApoB, and everything on the right of the slide, which is just HDL, has ApoA. And anything with ApoB is atherogenic. So if you have a structure that's carrying cholesterol and triglycerides through the blood, and it has ApoB on it, it is potentially atherogenic. How does that happen? So ApoB is the thing that actually will adhere to the vessel wall. It then, once it gets stuck there, it gets modified through an inflammation process that Dr. Green mentioned. This leads to further damage and the beginnings of atherosclerosis. And again, just to emphasize, the VLDL, IDL, LDL, chylomicrons, and chylomicron remnants all have ApoB. Those are the things that can lead to atherosclerosis, and those are the things that we care about. And understanding this basic framework, I think, helps us understand some of the findings in our studies. So how do we assess cardiovascular disease risk? Generally, we have taken the LDL cholesterol value as our traditional measure. And just as an aside, when we say LDL cholesterol, what we mean is how much cholesterol is in that sample of blood that we took that is found in this box that has ApoB called LDL. That's what it is. There's not a specific type of cholesterol that is LDL. It's really how much cholesterol is carried in this box called LDL. But LDL is not the only thing that has ApoB. In fact, everything that carries cholesterol that isn't HDL has ApoB, and that's an even better measurement. And it's even better if you can just measure ApoB, which we do sometimes, but we typically try to keep it as simple as possible and just measure the LDL cholesterol, because that gives us a pretty good idea. But you can see that we could measure just the ApoB, and that would tell us how many boxes out there carrying cholesterol and triglycerides could lead to atherosclerosis, with the idea that the more you have, the more likely you are to develop atherosclerosis. And of course, this isn't the only factor that leads to atherosclerosis. There are a number of other factors: your diet, your physical activity, your sleep, whether you smoke, if you have certain diseases, like possibly celiac disease, but diseases that lead to increased inflammation. Those can all lead to the vessels being primed for atherosclerosis. So we want to really use a holistic approach, and that's what we try to do with the risk calculators we have. And as Dr. Green said, and I couldn't agree with this more, we need specific risk factor calculators for patients with celiac disease, because there's some special features that really change your risk. So let's get a couple things out of the way, because I want us to make sure we understand this as well. The LDL cholesterol value, so how many boxes of LDL are there floating through the body, is almost entirely genetically determined, at least 80%. Meaning your diet and physical activity are not going to change that value tremendously. I say that, and I saw a patient earlier this week, and they really changed their diet, and their LDL went down by like 30, almost 40%. And I thought, great, I'm putting together this talk, and I just had somebody show that these are just guidelines and not hard and fast rules, but for the most part, it's 80%. Triglycerides, on the other hand, certainly have a genetic component, but it's not as important a factor in determining what your triglyceride level is compared to the LDL cholesterol. And for the most part, this is going to be very responsive to diet, physical activity, sleep, etc. And when we think about changes that a patient with celiac disease may need to make to their diet, this is really where we're going to see the changes, is in your triglycerides, not so much the LDL cholesterol. So again, the diet has a minimal effect on the LDL cholesterol, and the reason we measure the LDL cholesterol is because it's a good marker of your total ApoB or apolipoprotein B particle amount. So how many boxes are there? How many things in your blood have ApoB that could lead to atherosclerosis is pretty well estimated with your LDL cholesterol. And it's a great risk factor, a very predictive risk factor, but the diet isn't going to have that big a role. So why would a gluten-free diet matter then? So unfortunately, gluten-free diets have to be modified so that they are tolerable to eat. And you do that by adding sugar, saturated fats, all to improve their taste. Oftentimes, because of the dietary restrictions, there's actually been almost a purposely driven, like these foods will just have more calories so you'll be full, because it may be harder to get all the foods you need with all the restrictions. So they tend to have a little bit higher calories. But not entirely. So before we go off, I like to go on these like little side tangents, as you can tell. I want us to know that when we think about anything we're saying, there's so much variability that we don't want to jump to conclusions too quickly. We don't want to just say, well, the foods that are available that are gluten-free are all just typically unhealthy for you, aren't fortified correctly, etc. We want to know that first, not everybody who has celiac disease is diagnosed at the same time or at the same age, I guess what I really mean. And so how that impacts your cardiovascular disease risk is very important to consider. Also, the adherence to the diet varies, and how much is tolerable can vary. It's not uniform. There seems to be a increased frequency of other autoimmune disorders, and as Dr. Green mentioned, and I mentioned early on, that inflammation plays a big role in promoting atherosclerosis. And while celiac disease may have some inflammatory or some pro-inflammatory features, the addition of other autoimmune diseases can really accelerate that process.
This is your 4-minute warning, Dr. Hartz.
Perfect, thank you. And lastly, it's hard to study these longitudinally because there's been some real improvements in the availability of foods. And also, I would just like to mention, it's not uniform around the world and definitely varies by race and ethnicity. So is everyone the same? Again, no. If you follow a gluten-free diet and you may actually have better intestinal absorption of foods. This may lead to an increase in weight. Is this just over the short term? Once you get adjusted, do you reduce your consumption? I think that varies. We mentioned the unbalanced micronutrient profile leading to insulin resistance, which then leads to your high triglycerides. Again, is that a long-term effect or something that's more short-term, and has that changed with the new availability of foods? And then some compensatory eating behaviors, which sort of is really meant to kind of encompass all of these changes rather than focus on specific nutrients. So a lot of the literature is focused on the role of obesity in patients with celiac disease, especially in young kids where it's harder to have hard outcomes like a heart attack. And so some interesting statistics to just kind of mull over is at diagnosis, the number of patients who are overweight varies from 10 to 20%, with about 6% of those being obese. And in the pediatric population, obese is above the 97th percentile. And then after the gluten-free diet is introduced, how does that change? And there seems to be an increase in the BMI in those patients. It really goes from rates from 11% to 21% for one study, so almost doubles. But the rate who are obese actually barely changed at all, if it did. But obesity is just one factor that of your cardiovascular disease risk. And as I've mentioned, we've really focused on the development of atherosclerosis. And we need to take these studies as just one part of that equation leading to atherosclerosis. So when we look at the literature in kids, at least, and through adults, we see a higher rate of high BMIs in adolescents who are on the gluten-free diet, which is confusing. However, if you were obese and you start a gluten-free diet, it may reduce your BMI. These are conflicting data. And then I think the most important thing to think about is how the lipid profile changes. And for younger patients, we see a decrease in cholesterol, a decrease in LDL, and a decrease in triglycerides. And that I think the diet actually improves in your younger populations, whereas older patients, maybe there's the cholesterol more or less doesn't change. And then studies have focused on finding this increase in the HDL, but I'm not so sold that's an important factor given its limited role in the development of atherosclerosis because it doesn't have ApoB. So let's assess our risk then. Patients who are adherent to the gluten-free diet in adolescents, they have lower carotid and intimal medial thickness, which is a measure of atherosclerosis. But, and it seems to be higher in patients who are not adherent. And this may show that the long-term adherence to the diet may actually prevent atherosclerosis. But that just conflicts with everything we just said in my mind. Does it? It seemed to maybe increase BMI. It may seem to minimally change your cholesterol, if at all.
Well,
What do we do with this?
1 minute warning, Dr. Hartz.
Perfect. Last slide.
Thank you.
So I think the most important thing to think about with this is if you know how the diet affects your lipids, primarily that it's going to affect your triglycerides, we can worry about teasing some of these other factors out a little bit less and understand that what we really want is to get a general risk of patients with celiac disease, what their cardiovascular disease risk is over their lifetime. And secondly, understand where would the gluten-free diet really impact. And so the most recent meta-analysis showed about a 10% increased risk in cardiovascular disease, but that the untreated risk is even higher. And so the three things I would have you remember is your LDL value is determined mostly by genetics, so don't get too hung up on that with the changes in your diet. triglycerides will respond and could be a nice marker of adherence to the diet as well as the quality of that diet. And it's regardless, it's essential to have a healthy diet with or without gluten for everybody to reduce your overall cardiovascular disease risk. So thank you so much for this opportunity. This was a real pleasure.
All right. Thank you so much, Dr. Hartz, for just an excellent presentation and explaining all of those details from a cardiology's perspective. So I'd like to now introduce our third speaker, and this is Cristian Costas. Cristian is a clinical specialist and gastroenterology dietitian specializing in celiac disease. He established and runs a dietitian-led celiac service at Bradford Teaching Hospitals in the UK, with the support of his gastroenterologist colleagues, and he's involved in celiac disease research. He is very passionate about sharing evidence-based information about celiac disease and the gluten-free diet on social media. He has won multiple awards for his work in the field of celiac disease as it relates to clinical practice, research, and social media, and his main areas of interest are celiac disease service development, gluten-free diet adherence, and evaluating the effectiveness of dietitian-led celiac services. And so, Cristian, I'd like you to now share your screen. Thank you.
Sure, thank you. Thanks, and thanks for the introduction and for inviting me. It's a true honor to be here, and with such a fantastic team of speakers. Right, can you see my slides now? I think, let's have a look. I hope everyone can see my slides. Haven't heard anything, so hopefully that means it's all good. So as I said, it's a tremendous honor to be here, and I'm really excited to talk about the role of a heart-healthy, gluten-free diet in pediatric and adult patients with celiac disease. These are my only disclosures, though none of them are relevant to this talk. And I'd like to start off by talking about the factors that contribute to the development of cardiovascular disease. I think we've had two fantastic talks from Dr. Hartz and Dr. Green talking about some of these unmodifiable risk factors and talking about some of the things that we can focus on with these modifiable risk factors too. And as you can see from this brilliant diagram, we know that what we class as unmodifiable risk factors in cardiovascular disease are things like age, gender, genetic factors, race, and ethnicity. But I think we can also class celiac disease in there. Once you diagnose, there's not much we can change there about the diagnosis. We can't really reverse it. And we know from the two talks we've had there's an increased risk there from a cardiovascular disease point of view, but it's about what we can do really. And these modifiable risk factors are things that we have to definitely consider. We have to think about things like obesity, hyperlipidemia, high blood pressure, alcohol intake, cigarette smoking, and diet too. And diet-related risks account for about 10 million, or about 52%, half of cardiovascular disease deaths worldwide. So diet plays such an important role when it comes to cardiovascular disease. And that's why I'd say that some of the key steps we want to always focus on when someone gets diagnosed with celiac disease is to start off following the gluten-free diet, making sure we're doing that right to reduce that systemic inflammation, making sure that diet's then optimized, and also making sure we're optimizing lifestyle. It's not just about diet. We need to optimize these other things within lifestyle to really give people the best outcome. Now, as Dr. Green alluded to really eloquently, when we talk about the gluten-free diet, we only define it by what we remove. And that is an important thing to remember. We always talk about avoiding barley, rye, and wheat and oats in those people who are sensitive to gluten-free oats, right? But that's a very small percentage of patients. And that's why our focus as dietitians really is trying to select these patients too and try to make sure we're never over-restricting the diet, because oats can be very beneficial too from a cardiovascular disease point of view, right? But for the purpose of this slide, really, it's to highlight that we define it by what we remove and not what we include. And that's why what we include is completely open. So there's no universal definition of what should be included in a gluten-free diet. And that means there is no one gluten-free diet. There are multiple gluten-free diets. And it really depends on what is included. And that's why it's so hard to determine the role of the gluten-free diet in these different studies, because the diet gets applied in so many different ways. Now, I'd like to focus on what heart healthy diet should look like. So we can start off with that. And we've got this brilliant diagram from the most recent guidelines from the American Heart Association, which really suggests that we emphasize things like fruits and vegetables, whole grain foods, which have been talked about, which can be more of a challenge when gluten's removed from the diet. That's why it's really important we start to focus more on gluten-free grains. I'll be talking about that too. That we incorporate healthy sources of proteins. So we incorporate fish, seafood, legumes, nuts, things like low-fat or fat-free dairy, and then lean meat. So we've got poultry or lean meat, people eat them, and then some liquid plant oil, so soybean oil, olive oil, canola oil, and then that we minimize things like food and drink that's got added sugar in it, highly or ultra processed foods. But it's important to, with diet, I think it's always really important to say things aren't black or white, right? So some foods in the ultra processed food category can still be beneficial. As we were talking about some of these grains that we talk about, they can sometimes be in the ultra processed food category. So it's important to not look at it as just black or white, but we'd want to minimize foods that are highly processed, have high amounts of fat, sugar, and don't have much nutritional value. And we want to reduce things like processed meats, foods high in salt, alcohol, and then some of these tropic oils like coconut or palm oil too. And we want to make sure energy intake is adjusted, maintaining a healthy body weight, and following a lot of this guidance really, regardless of where food is prepared or consumed. So it's sustained longer term. Now, that's a lot of these general components. People will understand a lot about that already and be aware of it. So I thought it'd also be helpful to give some more specifics. And this, again, was another really nice study that summarized a lot of the guidance when it comes to cardiovascular disease and a lot of the evidence. And I think these are some really useful specifics. So a lot of what we want to try to do to reduce the risk of cardiovascular disease is reduce saturated fatty acid intake if it's higher than 10% and start replacing it with things like polyunsaturated fatty acids, which we can find in things like oily fish. We can find that in some nuts and some seeds. We can find that in some other foods, same as monounsaturated fatty acids I will talk about later. So changing some of these types of fatty acid can help, because a lot of people might be consuming foods that have more saturated fats, which we might find in things like more animal products, especially the ones that have got more fat in them. And then we might find that in some bakery products, in some cakes, biscuits, a few of these other foods. We also want to reduce trans and saturated fatty acids. So we know we want to keep these as minimal as possible. And again, we tend to find these in highly processed foods with low nutritional value. So again, we want to reduce those. We want to try to aim for less than 5 grams of salt, which is about a teaspoon of salt per day. So that's important to consider when cooking too, and when buying certain products. And we want to have a high fiber diet, something like 30 to 45 grams of fiber. And I always talk to patients about this, about having a look at how much fiber we're actually getting, because most people aren't getting enough. For example, in the UK, the average is about 18 grams of fiber, even people who don't have celiac disease. So once diagnosed with celiac disease, can be a bit harder. It's definitely achievable, but we've got to consider a few things to really optimize fiber intake. And that's why it's important to have things like 2 to 3 servings of fruit, 2 to 3 servings of vegetables. It's also important to have fish once a week, preferably oily fish, and really limit alcohol consumption. And I think this is why the numbers are important here. So we want to aim for no more than 100 grams of alcohol per week, but you can see some examples that represent 10 grams of alcohol. So something like half a pint of beer, it's already 10 grams, or a small glass of wine, or a shot of a spirit, really. So something like 5 pints of beer a week is already enough. And a lot of people can be consuming more alcohol than this, and in a short period of time too, without realizing. So it's important to mention that. And again, we want to we want to reduce things like sugar, sweetened soft drinks, and sugar overall should, especially the added sugars that we find in diet, it should be no more than 10% of the total energy intake. And we know there's benefits to consuming unsalted nuts, so having something like half or 1 serving per day, and shifting more towards a plant-based diet with less red and processed meat. And I'll be talking about that too in some of the upcoming slides. So when it comes to children and youth, we've got this really nice guide from our Canadian colleagues, and I think it's a really nice visual illustration where it really talks about having more than 50% of fruits and vegetables on that plate, having some good sources of protein, both animal and plant-based sources. And again, if people don't eat animal-based products, it can always be plant ones too, and having gluten-free grains, but aiming for these gluten-free grains. I'll talk about this in coming slides too, ones that have got more fiber in them, more protein, this is always beneficial. And we want to limit the consumption of gluten-free processed foods in there, and choosing foods that have got a good amount of folate, iron, and fiber, which will be some of the ones I'll be talking about through these slides, and making sure that any milk that's consumed really that is unsweetened ideally, and fortified with vitamin D and calcium if it's not a dairy, if it's not dairy milk. So really, when we're talking about a lot of these things, I know I've given you some general components, some specific ones, but I think when we talk about diet, we shouldn't just focus on individual foods or nutrients. We need to look at dietary patterns. We need to look at the big picture. And again, this was a really nice study that looked at some different diets and checked how they were aligned with the American Heart Association recommendations. And you can see some common diets that people will be aware of, like the paleo, very low carb, low fat diet, vegan, and then different versions of vegetarian diet, Mediterranean, and the DASH style diet, or the dietary attempts to stop hypertension, and that's also known as the Nordic or Baltic diet. So as you can see in all these boxes, the ones that had more of these green, or then some of these like yellow or amber boxes, but especially the ones that had more green boxes, were more in line with these recommendations from the American Heart Association, and they were in this sort of tier 1 section. So the most aligned ones were these ones I've suggested here at the top. And really what the authors concluded was that there was robust evidence supporting diverse dietary patterns, particularly from these ones like the DASH, Mediterranean, pescatarian, and vegetarian diets, that promote cardiometabolic health, and that can be designed to reflect personal and cultural preferences and budgetary constraints. So I think this is so important, because it's really not saying that there's just one diet that beats all of them, and that we can adapt these diets to meet people's needs, because everyone is completely different, as Dr. Hartz was saying, from a diagnosis, how they present, but also how they can implement the gluten-free diet and how we can support them with it. So really, to give a bit more detail on that, there's a nice diagram here which shares those 3 patterns, but it's about looking at what's in the middle, what's common to these 3 dietary patterns. And we know that these 3 dietary patterns mainly emphasize things like vegetables, fruits, whole grains, or in the case with a gluten-free diet, be gluten-free grains, but it's legumes, nuts, and seeds. And again, some of these will incorporate a few other things like extra virgin olive oil. There might be some fish or seafood, depending on the pattern, dairy, eggs too, some lean meat, but really they limit a lot of these things like fatty meats, refined grains, added sugars, alcohol, pastries, sweets too. So there's a reduction of these foods. So I think the key thing is that we focus on the dietary pattern more than specific nutrients, and that the diets can combine dietary patterns from different diets. It's not just about picking one. We have to focus on the individuals, so we get a dietary pattern that's sustainable for that person and meets their needs and preferences, including their cultural preferences too. And the question we get a lot too is, can some of these dietary changes for heart health help achieve a healthy weight? So many of our patients feel like, oh, I've got to do a gluten-free diet, then a diet to lose weight, then a diet to improve my heart health. It's about finding the common ground. So as has been highlighted already, we are seeing an increased number of patients who might be overweight or obese. So this review found about 37% of patients with celiac disease were overweight or obese at diagnosis. But we see quite a few changes, and similar to this review that looked at adults and pediatric patients, found that there was a BMI increase in quite a few patients, but only 9% of patients changed from underweight to normal BMI category, and then to the overweight or obese category, and 20 moved into the lower BMI category. So again, there's quite a lot of variance, but we do see quite a few patients who will either gain weight or struggle with excessive weight gain or fat gain after diagnosis and once starting the gluten-free diet. And then there was this nice review that really looked at a lot of trials, randomized controlled trials, different meta-analyses with regards to the Mediterranean diet, and found a greater reduction of body weight and BMI with the Mediterranean diet compared to other diets, and a reduced risk of becoming obese and gaining weight over time associated with higher adherence to the Mediterranean diet. That's why I think we need to also look at what we're including in the diet rather than just weight as a whole, because that can be beneficial for many different things. And what this study found was that a lot of these obesity related conditions were inversely associated with the Mediterranean diet. So So cardiovascular disease, some of these different types of cancer, cognitive decline, depression, type 2 diabetes, and metabolic syndrome too. So it's important to focus on what we're including in the diet. And really, to summarize a bit of some of these tips to achieve a healthy weight and a heart-healthy gluten-free diet, I think it's really important that we're focusing on having a predominantly naturally gluten-free diet, that we aim for something like 30 to 40 grams of fiber per day from different sources. And one of the key sources is these gluten-free grains. That's why really figuring the patients who can tolerate gluten-free oats and incorporating that. Quinoa, buckwheat, millet, teff, amaranth, sorghum. There's a lot of these different gluten-free grains that are more and more readily available. And especially in the context of some foods that are not fortified, we need to really start to focus on making the diet as inclusive and diverse as possible. Having plenty of pulses in the form of beans, lentils, chickpeas is really important. A lot of people don't consume enough of these. Having unsalted nuts, but different nuts too, peanuts, cashews, pistachios, walnuts, almonds, and many of the different ones. And again, with seeds, getting a good variety in there: pumpkin, chia, flax seeds, or linseed, sunflower seeds, and again, continuing to mix them up and having different ones, consuming white fish and oily fish, having plenty of different fruits and vegetables, which is why we say always try to eat the rainbow or aim to incorporate all these different ones, seeking higher fiber foods. If you're buying gluten-free processed foods, I think the market has really changed. And now a lot of companies are aware that it's not just about having a gluten-free product, but having something that adds good nutritional value. So look for a combination of higher fiber gluten-free foods. Check to see if they're fortified. Some of them sometimes will be fortified because the company wants to do it, and check for better nutrient profiles in some of these foods. Cooking mainly with plant oils like olive, canola, rapeseed oil, rather than things like coconut, palm oil, or animal fats can be important. And really looking at physical activity is also key, trying to aim for adults 150 minutes per week and more for children. Again, this is a very rough guide, but this is the minimum. And I think that's a really important thing that we mustn't forget. And again, a lot of this physical activity can also help with bones and bone mineral density, which is important in celiac disease. So there's many benefits for a lot of these different things. And we want to try to limit or stop alcohol.
2-minute warning, Cristian. Thank you.
Thank you very much. Just coming on to the conclusion next. We want to limit food and drink with added sugars, aim for less than 5 grams of salt per day, so aiming for around 1 teaspoon. We want to limit processed meats, again, stop smoking if anybody's smoking, and reduce some of those saturated fatty acid fats, as we were saying, and replace with monounsaturated fats where able. So extra virgin olive oil, things like nuts, seeds, avocados, some of these other foods too. So again, there's a lot of benefits to adding some of these plants into the diet more routinely. So some of my main conclusions are that I think it's important that once people are diagnosed, that we switch from unconscious historic choices that we've already made, where people sometimes will say, right, whatever I had before, I just had the gluten-free version of it. It's an opportunity to really focus on conscious, healthy eating habits. And the good thing about this is that we can focus on inclusion rather than restriction to achieve a heart-healthy gluten-free diet by looking at what are the beneficial things we can include more of. And we know there's a lot of benefits to adding more fruits, vegetables, pulses, nuts, seeds, gluten-free grains in there. We know that the DASH Mediterranean vegetarian diets are dietary patterns most in line with cardiovascular health recommendations. So, versions of these can be beneficial, or if people want to follow different, want to adapt them in certain ways, it can help. Some of these changes can definitely help reduce cardiovascular disease risk and help achieve a healthy weight. And I think that's why it's so important we have sessions like this where we're bringing education to patients to support them so they're aware of the changes needed to optimize the gluten-free diet from a heart health point of view. So thanks a lot for listening, and I'm looking forward to joining the panel to answer some questions.
All right. Thank you so much, Cristian. That was awesome. And thank you to our 3 speakers for this comprehensive presentation today. I'm going to now open it up to Q&A, and I'm going to start actually with Cristian. There are a lot of questions for everybody, but a lot of questions on nutrition. So as Dr. Green especially pointed out, the role of whole grains plays an important role in cardiovascular health. And so what are some of the safe gluten-free whole grains that you would recommend, also paying attention to minimizing cross-contamination as well as reducing the risk of heavy metal contamination?
Sure. I think it's about, I think the key thing here is about availability, right? And I think people in different countries, different areas might struggle to get a hand of some of these gluten-free grains. But I think as much as we can include a lot of the ones that I listed, so for example, oats is a really important one, I would say. If people can tolerate, and that's why I say the follow-up is so important, because so many people hear about oats that there's a small percentage of patients that have to restrict, and a lot of people just restrict it from the onset, right? So I think that's a really important one, just restricting in the patients where it really needs to be restricted, where we talk about gluten-free oats. But I think all of the other ones like buckwheat, millet, amaranth, teff, sometimes you will find these in things like gluten-free pastas where there's a blend of some different flours, or you can look at pasta that's got some lentil flour in it rather than corn, for example, right? So just looking at some of these options where you can have it, and sometimes it might be harder for people to get the actual grain if they can, but some places they might be able to find it. And I think it's about incorporating that and mixing it with what people are having too. So I think it's, again, availability, we're there, but to try to explore it as much as possible. And then there's things like that can be done also, like rinsing, like what happens with lentils too, to sometimes reduce the risk of cross contact with some of these natural foods, and that can also be beneficial. So I think it's these steps to help people as much as possible to keep the diet inclusive is really important.
Mm-hmm. And then another quick question was about dietary cholesterol and types of fat. First, of like, how many eggs can I eat? Should I avoid yolks altogether? And are cow's milk products more inflammatory, especially for patients with celiac disease?
Yeah, good question. So I'm happy to answer some of that, but Dr. Green or Dr. Hartz, do you have anything that you'd like to add? But I get you'll get that question about the eggs quite a few times too.
I'd like to mention just a question about cow's milk. I think that there's actually too much restriction of dairy. Some individuals are lactose intolerant and they should restrict lactose, but it concerns me that they then have those products like almond milk and oat milk, and we really don't know what they contain. And I think there should be less worry about a diet being pro-inflammatory. I think there's not all that much evidence for that in addition. And so if someone is lactose intolerant, they should restrict lactose, but not necessarily dairy, because it's a wonderful form of calcium and very widely available dairy products.
I agree.
Thank you. Yeah.
I think I can address the egg question. First, I'd say this is the answer from Jacob Hartz, and you may hear differently, but I think I'm right. I think you are too. Okay, thank you. The American Heart Association guidelines no longer recommend you care too much about your cholesterol intake from foods because its association with cardiovascular disease is complicated, not clear, and there are tremendous benefits from eggs in that they have really good protein, and until recently they weren't that expensive. Gosh, they seem like they got so expensive all of a sudden. I think they're a terrific food, and so I don't limit the number of eggs. I will say that the only time I ever consider limiting eggs is if I think it's being consumed where you're not getting all your other foods you need to eat. And so if you're just eating eggs, that's not great. But I don't focus on cholesterol intake as something I'm asking patients to read on a label anymore.
Yeah, and I think it's in line with exactly what we're saying. The context is so important, right? So people get so bogged down on these individual foods, which we know there's no strong data for, but it's also what else are you eating? And I think in the context of someone having a lot of these plant foods in the diet, having good diversity, the amount of eggs that you eat is not really going to going to impact things. And same as what Peter was saying, so many people will see that we look at the more restrictive diets, the more restrictive component of things that I should avoid this, I should, but the evidence really isn't there. And actually, as many, especially a gluten-free diet's already restricted enough as it is. So we want to focus on inclusion, and people missing out on these ways of including more foods can be more detrimental for them long term, I think.
And
Yes.
just to piggyback on that, I think something that you may have, Christian, food's wonderful. It's not like a poison that we have to put in ourselves just to like power through the day. I love food, and I want us to enjoy the food we eat and have a really wonderful relationship with the food we eat and think,
Yeah.
oh, what
I'd
a
like
great
to
food.
follow up with that a little bit. I think it's very concerning, hypervigilance and anxiety about food that all of us, dietitians, physicians involved with the care of celiac patients, should encourage people to be adventuresome in what they eat. They've got to restrict gluten, alone, and so we've got to tread this delicate balance of being cognitive of restricting gluten, but not restricting one's lifestyle so that they can't enjoy eating and dining out and enjoying friends' company and not having to wash their hands until, we see individuals who have contact dermatitis from the number of times that they scrub their hands to avoid this possible cross-contamination. And I think we all should avoid the term cross-contamination because cross makes it very bad. It's just cross-contact or contamination. People need to relax more if possible.
The inclusion's the way forward, 100%.
Yes, thank you. We have another question, multiple questions on a similar topic, and this is really, I think Dr. Green and Dr. Hartz, you might be able to answer this. So since my GI doctor is a celiac doctor, should I also be seen by cardiology so that I'm prophylactically treating the risk of CVD? And then another similar question just asked about best practices for pediatric patients with celiac disease. Should they be screened more often or more frequently for lipid profiles, et cetera, just as a prophylactic measure?
I'll step forward. I think if the question arises, should I be seen by a cardiologist, the answer should be yes. We don't know enough about assessing the risk factors for individuals with celiac disease. So if there's any question, I think the answer is yes, and step forward. And I think we've got to educate our cardiology colleagues that an individual like someone with celiac disease who's skinny with a low cholesterol and low blood pressure actually has an increased risk, because I don't think the cardiologists are aware of this. So I think the more patients that go along and say, like, I need to be assessed, what are you going to do? I think that's a very good idea.
Yeah, I think that's probably a good idea too, because when you look at the literature and the science behind this, you're so impressed with the progress that's been made, and you're so impressed with the longitudinal data. And I think we're learning more and more all the time. And so it's probably not a silly thing to be assessed. And I'm hoping that general practitioners are putting it as one of the main objectives of the annual visit is where are you on your risk? That can be kind of time consuming, and maybe that's unrealistic for me in today's climate. But we're happy to see you, and you can find the right cardiologist who is interested in this and who knows something about it. I think you'll find them throughout the country. I would say for pediatrics, that's not a bad idea. I think the focus can be on the diet and physical activity with routine screening that we would recommend just to the general population for your lipid panel, which we usually recommend from 9 to 11, and then again somewhere 17 to 19. If you're working with a dietitian who's helping you develop very healthy eating habits and your children very healthy eating habits, that really would be, I think, sufficient. And then we'll catch the ones who are at much higher risk because of the inherited factors of the LDL with the general lipid screening. That way you don't have to go to too many doctors. But we're happy. I'd be happy to see you, and I do get referrals for patients with celiac disease where it feels like maybe there's a little bit more risk here, and can we tease some of this out?
Great. Thank you. Well, I wanted to, again, thank our presenters. I'm going to turn it over to Chris Rich just because of time. Chris will conclude our session.
Thank you, Sharon, and thank you to all of our presenters and attendees for your participation today. We hope that all in attendance found this webinar educational and helpful. Our next webinar is scheduled for May, so please keep an eye on the Harvard Medical School and National Celiac Association websites and social media accounts for updates and additional information. So from all of us here, we look forward to seeing you next time, and thank you for your continued support.